So we'll start as others are still joining, but I'll give the introduction because I know everyone's busy. So thank you for joining us and welcome to this Forest Fellows webinar. I'm Tim Colmer, the Deputy Vice Chancellor of Research here at UWA, and our speaker today is Georgia Hay from Curtin University. I'd like to start with an acknowledgement to country. It's the practice of our university to acknowledge that we are meeting on Noongar land and that Noongar people remain the spiritual and cultural custodians of their land and continue to practice their values, languages, beliefs and knowledge. And I pay my respects to the elders past, present and emerging. So as I mentioned, we're really pleased to have Georgia Hay from Curtin University as our Forest Fellow today giving the webinar. The topic is why diagnosing rare diseases is about more than medicine. So in this presentation, Georgia will discuss her research program on the psychology behind rare disease diagnosis, which aims to understand the cognitive and psychosocial factors that contribute to effective teamwork in this complex healthcare context. Dr. Georgia Hay is a Forest Prospect Fellow funded by the Forest Research Foundation, working with Curtin University Centre for Transformative Work Design within the Future of Work Institute. She conducts applied research on psychological dynamics and challenges related to work design, occupational groups, and managerial decision-making in organisations. So thank you everyone for joining us, and Georgia, over to you.
Thank you. I will share my screen. I think, does that look good to you, Tim? Thumbs up? Fantastic. And I will hide my face so I'm not staring at myself this whole time. Fantastic. Well, yeah, so thank you so much for having me. I suppose the intention behind this presentation, as Tim said, is to give you a bit of a sense of this project that I've embarked upon thanks to the support of the Forest Research Foundation. That's an extension of a project that I've been working on for the last couple of years, which centres around the diagnosis of rare diseases. So to give you a bit of a feel for the importance and also the prevalence of this issue, I'd like to tell you a little bit about Lily. So Lily, unfortunately, since she was born, had a lot of different problems with feeding, with her growth, and with lots of different organs within her body. And so at 7 years old, Lily had been in and out of the hospital quite a lot. So 50 inpatient visits, 250 outpatient visits, and 14 general anaesthetics by the time she was 7 years old. So Lily was obviously suffering from some sort of rare, multi-systemic, so problems with different organs and life-threatening disease. But medical experts in Western Australia and all over the world couldn't figure out what exactly this disease was. So although Lily had a rare disease, and by definition, rare diseases affect a small number of people in the population, that's how we define them, there are actually over 10,000 different rare diseases. So when you look at altogether how many different people are affected by these sort of complex multi-systemic diseases, that's about 350 million people worldwide and about 2 million Australians, which means about 8% of the population. So although you think of rare diseases by themselves as rare, collectively, these sorts of complex symptoms and really difficult to diagnose sort of diseases are actually experienced by a large proportion of the population. So as I alluded to, a lot of these rare diseases tend to be genetic, not all of them, but there is a large component of where genetic knowledge is needed to understand and to diagnose these sorts of diseases. And again, because they're so complex, they involve multiple parts of the body, and because they're so rare, they're incredibly difficult to diagnose. So what that often means for patients like Lily is that they go through what is called this diagnostic odyssey. So for about 25% of these patients, they'll go about or under 3 months before they find a diagnosis. 25%, it'll be about 3 to 12 months before they get a diagnosis. 20%, 1 to 5 years, and still 30%, 5 to upwards of 20 years without a diagnosis, let alone an idea of what potential treatment could look like if there is indeed a treatment available. During this time, as I mentioned, that these sorts of diseases tend to affect multiple parts of the body, which means often these patients are seeing multiple specialists. So a large proportion will see 1 to 2 doctors. Quite a few still will see 3 to 5. And again, quite a significant proportion will see 6 to upwards of 10 different specialists in an endeavour to try and find an answer. There's a really interesting study that looks at, obviously first and foremost, the challenge associated with not having a diagnosis is incredibly challenging for the patient and their family, but it's also incredibly costly for the healthcare system. So there was a study that looked at 2% of the WA population who had a rare disease and found they accounted for 10.5% of WA hospital inpatient expenditure at a price tag of $395 million. This was just inpatient expenditure, so not outpatient. And this was a study that only looked at 500 of the 8,000, 10,000, the number is ever growing, different rare diseases. So this is likely an underestimate. And the costliness of them is both tied to the treatment side of things, but it's likely that that diagnostic odyssey is also incredibly costly to the healthcare system. I suppose to also worsen perhaps this problem, as with many patients with kind of pre-existing conditions, the impact of COVID in particular is making this challenging environment and these difficult to often live with illnesses even more challenging, both in terms of access to perhaps treatment, ongoing treatment that these patients are using. It also makes the diagnostic odyssey even more challenging for many reasons that I'm sure you can imagine. And unfortunately, these sorts of patients often, there's early evidence to suggest that they struggle, that there's increased mortality related to COVID with these patients. So a particularly complex group of illnesses that now even more so is particularly important to support these patients and their families. And also, from my perspective in particular, the clinicians who are doing their very best to diagnose and care for these patients. And there's also this statement that a fantastic advocacy group, Rare Voices Australia, has put out, emphasising this need to consider patients with rare diseases in the context of COVID. So I think I mentioned in the little blurb that was put out for this presentation to try and, for those of you who maybe don't have someone in your family who has a rare disease, I'm sure most of you have probably had the experience of going to at least a couple of different specialist appointments. Probably waited a long time to get in. You wait a long time at the clinic and you go in and get told that no, it's not anything to do with your immune system, or no, it's not anything to do with your heart or your brain or your whatever it is. You pay a lot of money, then you leave, and you kind of have that feeling of, oh, well, what now? If you don't know the answer, who does? And so that's gives you, I think, a little bit of a sense of what part of the structural issue is for these patients who have rare diseases. And that is that our healthcare system is increasingly siloed. And that means that patients then themselves, and often with their families, particularly when they're children, have to move themselves from specialist to specialist to specialist to specialist in an endeavour to get the knowledge that they need to hopefully find a diagnosis. So early in my still early academic career, I was introduced to Gareth Bainham and the team who make up the West Australian Undiagnosed Diseases Program. And essentially, it's, fundamentally what they're trying to do is quite simple, and that is go from a siloed healthcare system where specialists are isolated in their kind of disciplinary boundaries and bring them into one room. And to do so with the assistance of a supportive program infrastructure and technology, but really just the opportunity to talk to each other face to face and to spend time going in depth into a patient's case to try and figure out what might be wrong with them, what clues are there, what might have been missed, how can we really get to the root of this highly complex, likely very rare disease. So when I first met Gareth and the team, obviously this is just one example of an undiagnosed diseases program. There are many popping up across Australia and many indeed across the world as well, in an endeavour to end this diagnostic odyssey by bringing together the specialists into one room. What they're doing is really at the forefront of science and technology, and particularly genetic testing and genomic sequencing technology. But also what they're fundamentally doing is it's people, and it's the ability to come together and communicate and collectively brainstorm and apply that technology. And what we're often seeing is that while the medical science and the technology is incredibly advanced, the social or psychological science of the teamwork element is a bit underdeveloped, and that's where my research comes in. So another challenge that you might find that's relevant to this context is you might have found, whether it maybe was a doctor or maybe it was someone, a relative at a barbecue who was telling you about the work that they do. And even though perhaps they're speaking technically the same language, you really are not quite understanding what they're saying. And this, funnily enough, although the different medical specialists who need to come together to diagnose and support rare disease patients, you might kind of think, oh, they're all doctors, they all speak the same medical language. And to an extent they do, but because in addition to being increasingly siloed, with the rapid advancements in science and technology and medicine, specialists are becoming more specialized. So there are actually some communication barriers that arise when you bring these specialists out of their silos into the same room. They, to an extent, have a basic kind of fundamental medical language, but there are, as you can imagine, the degree of their knowledge at the frontiers is definitely not shared. So there's a real need to understand how to best combine that knowledge together. Another factor that's relevant from a psychological perspective, and you may have found this in your work environment or otherwise in a social setting, where you had something to ask or say, but you felt that it was kind of silly or not appropriate. As I mentioned, rare diseases are at the frontiers of medicine often. So typically the types of patients that are going through this diagnostic odyssey and come to an undiagnosed diseases program, all the normal stuff has been thought of before. So there's really a need to ask the silly questions and come up with the silly ideas. But historically, what we find in medicine and in healthcare is that there's quite a hierarchical culture. So particularly in healthcare environments, people are often, medical professionals are often very reluctant to raise those silly ideas or silly questions. So these sorts of things, I kind of mentioned psychology here and there, and I'm sure to some degree, depending on your background, you have an understanding of what that is. But there, to make it really clear, I suppose, there is in general increasing recognition that healthcare is not just about medicine. While it's obviously the fundamental basis of it and incredibly important, that when you have an environment where you're trying to get people to do things together, there are these what's sometimes called non-technical or people-related concepts such as leadership, communication, teamwork, that also will have an effect on patient outcomes and organizational outcomes. One particular example of where this has been become increasingly well documented is the contribution of poor communication to medical error, particularly in operating theatre teams. So that example of a silly question where a nurse might feel uncomfortable asking the surgeon, oh, you sure that's the right leg? And that often happens where and leads to kind of disastrous outcomes. So when I say organizational psychology, or psychology in general, you might think of lying on the couch and someone kind of asking how your day has been or how do you feel about that. You may or may not recognize this gentleman, Sigmund Freud, who was a pioneer of early psychology and said some interesting things about the psychoanalysis of dreams and some other things that have carried through to today. You might think of kind of looking into the future when you think of psychology. I'm pretty sure most people at least in my early days of studies, I mentioned I studied psychology, said, oh, are you going to read my mind? Can you tell what I'm thinking? You might think of organizational in this sense, does it spark joy? Or you might be familiar with some, I suppose, people that are kind of operating at the boundary of psychology and other disciplines of knowledge, or talking about essentially psychological topics like Simon Sinek. Or you may or may not have done the Myers-Briggs personality test, which I won't say much more than that, but if you want to have a long conversation with a psychologist about the validity of that, I'm sure many would be happy to chat to you. But so these all sorts of, I suppose, topics are at the fringes of tapping into what is essentially organizational psychology. So psychology is anything to do with how people think, feel, behave, and react. And organizational psychology is simply the application of principles and theory in psychology to the workplace, and is one of many different disciplines or subspecialties of psychology. And ultimately, what really underlies the field of organizational psychology is this idea of an evidence-based practitioner model, or a scientist practitioner model, where it's about taking the theories and the concepts that we have in the research domain and applying them to this organizational setting. So with a bit of an understanding of the rare diseases context and the challenges in that context, and hopefully, for those who didn't already, a bit of an understanding of what organizational psychology is, I want to take you to the specific questions that I've been working on and am now continuing to work on to combine those two areas, I suppose. So there are two levels to this, in a sense. So one is what is from our perspective, maybe not to a biologist or a chemist, but a micro level psychological perspective. So what are the psychosocial factors that, when these clinicians come together and have these meetings in these undiagnosed diseases programs, what factors contribute to successful multidisciplinary teamwork within these programs? How are some of those typical barriers that I mentioned to teamwork, like that environment of not being comfortable sort of speaking up, or the hierarchy, or feeling like someone else is really sort of speaking another language, how are those typical barriers to multidisciplinary teamwork overcome? And how do these teams reach a diagnosis where patients have often gone years without one? And in some cases, these teams are able to figure it out in 45 minutes and get to what is probably the answer. What is also interesting about this project is that there are hopefully broader learnings about transformation in the healthcare system. So what these UDPs, I think, are a really interesting example of, and it's happening in other areas. It's not unique to have a multidisciplinary team in healthcare or in other areas, but it's a great example of a successful transformation of what was previously super siloed into a type and a way of working that is very, very collaborative. So what can we learn about how different undiagnosed diseases programs in different states and different countries, how they've successfully made that transformation, and how they've made these programs really embedded in a sustainable way in the healthcare system. So that's sort of a higher level focus of the current study. I mentioned that I've been working on this for a little while, and that's with the West Australian Undiagnosed Diseases Program with Gareth and his team. And then more recently, through the support of the Forest Research Foundation, I've been able to expand this project to go from looking at the fantastic work that Gareth and his team are doing to looking at other programs that are in various stages of implementation in Australia, but also a couple of different, I suppose, branches of the United States Undiagnosed Diseases Network, which has been operating for a number of years now. That both gives me and the team that I'm working with variation in some of the factors that we're interested in. So different people in these different teams, different ways of structuring the team and the program, but also, as you can probably tell and see and already thinking of yourself perhaps, massively different healthcare systems and very different national cultural contexts, you know, both obviously Western, but still different differences in cultural values to an extent that might shape the success of these programs and the structures that are needed to make them work. This project involves studying all these different programs. I'm currently in the midst of data collection, so that's my way of, I suppose, taking slightly the easy way out, I suppose, to some extent with this presentation and giving you some preliminary findings, some ideas of what we're looking towards, but not concrete, complete findings at this stage, so you'll have to stay tuned for that. But hopefully what I can give you a bit of a sense of is the type of information that we're collecting, how we plan to analyze that data and some of the specific questions that we have, and then a bit of a sense of what the implications of that might be. So this project has qualitative and quantitative components. Myself and my team have been conducting interviews, I think we're over 100 now, with the different clinicians, so different specialists, geneticists, cardiologists, but also people on the laboratory side of things. So genetics, as I mentioned, has incredible genetic testing technology and sequencing technology that I won't even begin to pretend I understand, but there's the lab side of things, the computational side of things, as well as the clinical side of things. So having conversations with all of these different specialists about both how the program was implemented, so that process of change, and also how the program functions and what's unique about the program. Okay, the other one could have been objective, but it said subjective insights. So the subjective insights that we get from that are individuals' perceptions and experiences of what it's been like to work in this team. So what has it been like for them to go from working by themselves or in relative isolation as a specialist to being thrown into this team with experts in the field, incredible technology and finding diseases in patients that have just been published last week in the literature. So their experience of working in the team and what the team environment is like, is there that strong sense of hierarchy? Or if not, why do they think that might be? What they've learned from being involved in the program, how their viewpoints and skills might have changed. And also their sort of subjective perception of what they think is helping the team work together really well and what gets in the way. In addition to getting those sort of insights through interviews and also looking at some documents around that describe how the program works, we also record what they call the expert panel meeting. So that photo I had earlier of Gareth and his team when they come together, and that is sort of the core element of this program. So we have been recording the meetings that they have when they come together and try and figure out what's going on with the patient. So what we do, we have an application that we've developed, the communication analysis tool, which is essentially just a digitized way of making observations about the particular types of communication behaviors that are happening in those meetings. So we use particular theoretical constructs that are well established in the psychological literature, and this is one example that essentially says there are two types of behaviors that are really important for creativity, which is essentially what these teams are trying to engage in. One type of behavior is knowledge exploitation, which is situations in which knowledge is being used in an attempt to reduce uncertainty and converge towards an answer. Obviously very important in this context, but also this idea of knowledge exploration. So behaviors or things that people say to open up new possibilities, to shift the frame of thinking, to ask questions, point out maybe a symptom or a test result that looks a little bit funny that they're unsure about, and to open up a discussion around what that could mean for the patient. So we record the meetings, we get transcripts, we break them down into little itty bitty chunks, and then we code the particular behaviors that we're noticing that different individuals are engaging in these meetings. And what that can give us a sense of is we pair that with the interview data, which gives us a sense of people's individual subjective experiences. But then through looking at these meetings, we can see what is actually happening here at a micro level that takes a patient from years without a diagnosis to a diagnosis in sometimes 45 minutes. So we can pinpoint which sequences and patterns of interaction are associated with a diagnosis. We end up with the transcripts that look like this with the particular behaviors. And what we also do is we administer surveys to the team at the end of the meeting. So we get their perceptions of the effectiveness of the meetings. We also look at we do the survey pre and post the meeting. So at the beginning, we ask them what their ideas are about what the diagnosis could be and their confidence, their degree of confidence in that idea. And then we measure that at the end, and we look for a change in that, in addition to a change in what they think the diagnosis could be. So through pulling that information together, we can get a sense of the different patterns that are associated with perhaps an increase in diagnostic confidence or a complete change in the ideas about what the diagnosis could be. And we can get a sense of what does an effective meeting look like at that really micro psychological level. So that's, I suppose, a bit of a sense of the different types of information that we're collecting to get a sense of what helps these teams and these programs to work effectively. I want to give you, I suppose, some preliminary insights or a bit more of a concrete insight into more specifically what we're finding and what we're looking at. So I mentioned that one perspective that we're taking is this sort of more macro level perspective. And so this is a paper that we've already published. We're specifically looking at the West Australian Undiagnosed Diseases program and looking at the path they took to going from a siloed system to a more integrative, collaborative program. And the way that we did that is that we used a particular framework from socio-technical systems theory to map what that diagnostic odyssey looks like before the program, and then look at what it looks like after the program, and pinpoint the different factors that helped or got in the way of that change. So it's a bit, I suppose, to some degree, a bit complicated, but I'll just point out the key parts. And essentially what you can see here in the undiagnosed diseases program system is that the patient is going, P for patient, is going from clinician to clinician, from hospital to hospital, passing through all these different institutional informational barriers where things can get lost or go wrong or be mistranslated. And it's very much dependent on them to navigate that themselves. Whereas what you find when you have this centralized breaking down of those silos is that it's much more patient-centric, and there's the opportunity for, less opportunity for information to be lost, and much better flow of information within the team, is essentially what that says. And we documented a number of different factors, which I won't go into in incredible detail, but you can have a look at the paper if you're interested, or let me know if you want to chat further. We looked at the design stage of the program, where they were really integrating international models, tailoring that to the WA context, consulting obviously with relevant stakeholders, to the implementation stage, where really the importance of having particular champions for the program, finding resourcing synergies with existing programs or departments, and at the more individual level, kind of navigating some resistance to the idea of the program through relationships and demonstrating success. And then also to the operation stage, where the program's implemented, how do we keep it going and keep it successful? How do we keep clinicians engaged in the program? There are a number of different factors that prove to be important at that stage. So that was kind of a higher level perspective, I suppose, on the implementation of that particular program. And that perspective is something that we are in the process of replicating for the other programs that we've studied, but that was just the WA program. There are a number of different, I suppose, more micro level questions that we have and that we hope to answer through comparing these different programs. So I haven't actually mentioned earlier, I realize now, but historically, very few rare disease patients got diagnosed, around 2%. And this is, fairly common in Australia, that statistic. Most UDPs in Australia, and also the ones that I'm hearing, having conversations with in the United States, are currently at a diagnosis rate of about 50%. So on one hand, massive increase, fantastic. But obviously that means that these teams are still failing to find a diagnosis half of the time. So what I'm working with one of my honours students on is really focusing on how clinicians experience this work, where, to some degree they're failing a lot of the time to find this diagnosis. And they're going through the diagnostic odyssey with the patient. So what we're exploring through interviews with clinicians from a number of these different programs, from a number of different specialty backgrounds, is asking them to what extent they see this lack of diagnosis as a personal or sort of professional failure. Asking them if they do, how do they cope with that? How do they cope with the uncertainty? How do they cope with, often for years, kind of butting their head up against the wall, trying to figure out what's going on with these patients? We're looking at the emotional side of things, so using existing theory on emotions and coping to understand how different emotions are tied to these experiences and how they might cope with them, coping mechanisms. And also what we're interested in is comparing their experience before their involvement in these sorts of UDP programs to now they're in the program. So what was it like for them as an individual when they were previously trying to find diagnoses for patients, and how has that experience changed, hopefully for the better, by being surrounded by a supportive sort of team environment. And we're definitely, I suppose preliminarily seeing some interesting differences where for some clinicians they take it very personally and really I think in some instances, have to really battle through those emotions to kind of, you know, come to work the next day. For many people, particularly in the genetics realm, this is their bread and butter. They're, you know, constantly dealing with patients who are difficult to some degree to diagnose, and I think they go through a bit of a process of learning how to cope. But I think there's certainly what I hope will be implications from this study is understanding how, as a healthcare system, we can better support the clinicians who are doing this type of really challenging work. Another perspective that we're exploring at the moment, particularly through the interviews, is understanding how the different occupational identities that come together in this team, which historically we've found and has been identified in the literature are quite strong in healthcare in particular, how they're blended almost to come together as one cohesive team. So, you know, there's massive literature on essentially the tenet that if a team has this sense of we rather than I, they're more both more comfortable speaking out with those silly suggestions, have better flow of communication, and they perform much better. And that, I think that probably makes intuitive sense to a lot of people, and hopefully to a lot of you listening. So that is harder to do when you're in these multi-occupational teams. So what we're interested in is how these different occupations are blended together to develop a sense of a cohesive team in this context. And so that's specialists, again, we've got genetic counsellors, nurses and nurse practitioners, really diverse set of occupations. And, you know, I suppose, again, preliminarily, some things that are coming up are, first and foremost, I think the extreme nature of the work that they're doing. You know, these clinicians rather are coming together to try and help a patient who to some degree is just really, really keen for an answer. So I think that sense of need and patient need, and really quite severe sort of patient need, tends to draw everyone together and draw everyone's focus from, I'm not so worried about, you know, making a fool of myself by saying something wrong about genetics. I'm just here to try and help the patient. And then I think something else that helps is examples or instances where, and it's perhaps a little bit more challenging these days via Zoom, but opportunities for relationship building that make it, again, less so about I've been brought here to be an expert in my field, and more so about we're doctors together as people trying to help this patient. So any sort of experience or relationship building that sort of can equalize people tends to be something that is perceived as quite helpful, but this is still in progress. I alluded to earlier a little bit this other, which is more of a quantitative focus on when we have the data, the meeting recordings where we've coded them, we can get a bit of a sense of what patterns of interaction might lead to a diagnosis. And to give you a bit more of a concrete, I suppose, example of that, or to elaborate a little bit more, when we have these exploration and exploitation behaviors, for example, we can look at the degree of interactivity, I suppose. So, you know, for example, do you have one doctor who's, for the whole time, he's the one exploring, in a quite sort of, having a bit of a monologue session, and maybe coming up with a bunch of great ideas, but it's quite solo or individuals, or siloed almost still within the meeting? Or do you have this situation, which some of you might have experienced in your work, where it's not even that you sort of perhaps struggle to trace an idea back to the person who came up with it, because it's quite iterative and interactive. So, you know, I might say, for example, oh, you know, we have this test result, but this just looks a bit funny, and I'm not quite sure what it is, but it looks a bit wrong, or it looks a bit odd, or it makes me just think that there's something else there. And if I were an individual clinician by myself in my room, I would think that, and then that would be where that idea would end. But what we often find in these meetings is that because there's this team environment, someone else can pick up on that and go, oh yeah, you know, I also thought that was a bit funny. And I thought that maybe it could be something in this realm. And then someone else can pick up on that and go, oh, within that realm of diseases, I think it might be this one. And so we can look at the patterns in these transcripts of the meetings that we have, and look at the degree to which they're interactive, where different individuals are jumping in the sequence of behaviors. And is that degree of interactivity associated with whether that's interactive exploration or interactive exploitation or these switching behaviors. Is that degree of interactivity associated with the likelihood of finding a diagnosis through the meeting? And lastly, a study that's a bit more recent, and actually is great in the sense that it's a collaboration with another prospect fellow that I'm really excited to be embarking on. Also because it's a bit more multidisciplinary, which is, I suppose, a bit funny given that I'm preaching about the importance of multidisciplinarity in healthcare, but we often in academia tend to stay in our little silos. But I've had the fantastic opportunity of chatting and developing a research idea with a fellow who's a linguist. And what we're really interested in is, in these meetings, the role of humour in changing the dynamic of the meeting, and in a way that we think might be linked to how effective they are in terms of finding a diagnosis. And it relates, if you remember earlier, to what I was talking about around sort of when you're in these multi-occupational, multidisciplinary contexts, things that can help to equalise people. And there is a particular type of humour, which you can see here on this lovely little matrix called affiliative humour, and that's where it's joking that relates to the team. So it's a positive type of humour, but it's something about kind of a shared experience, as opposed to a positive type of humour that might be more self-focused. So there are these classifications that exist of these different types of humour. And there have been some theorising and some limited research around the role of humour in group effectiveness that says that it can serve a number of different functions. So humour in and of itself, it's just a positive sort of experience. It generates what we call positive affect. And that's been linked to positive team outcomes. You feel good, you do good stuff, you perform well. There's also evidence that it can decrease that hierarchical climate or environment and create what we call psychological safety. And again, that's just through kind of bringing everyone down to sort of the human level rather than the abstract level at which different kind of social hierarchies exist. It can also serve to kind of just create positive communication between leaders and the others involved in the team. Again, that sort of equalizing element. So there are a number of different proposed kind of theoretical pathways through which humour can support effective teamwork, but there's a limited research being done so far. And really what I'm excited about as well is looking at this from this psychological perspective, but looking at also the linguistic structure of humour in teams. So how is humour communicated, both in terms of, and this is definitely outside my field of research, so I'm going to definitely say something silly, the structural physical features of loudness and the way that speech comes out. And if there's any linguists listening, I'm so sorry, I'm completely butchering this, but also the structure of the communication, the structure of the discourse. And then the social element of that might be who is making the jokes, who is being humorous, and how does that translate to dynamics in the subsequent chunk of the meeting. We're particularly interested in how that might shape subsequent emotional expressions that then might be linked to meeting outcomes. So as you can tell, it's still pretty early stages, but I'm really excited to see how this slightly more multidisciplinary project and this linguistic approach can provide a new lens on the meetings and the data that we're pulling out of these meetings. A lot to put out there, and definitely, as I said, obviously still preliminary, still very much in the works. I'm 6 months into my 18-month fellowship, so really in the midst of it at the moment. But I've absolutely enjoyed the opportunity to speak to and work alongside these fantastic clinicians. So hopefully I've given you a bit of a sense of the challenge of rare diseases, the challenges of rare disease diagnosis. Hopefully I've convinced you of the importance of this psychological, social perspective in combination, obviously, with medicine and technology, and given you a bit of a sense of some of the interesting puzzles that we're trying to dig into within this context through the different avenues of data that we're collecting, but still very much in the works. So if you're interested or you want to chat further, I'm more than happy to chat and keep you in the loop with the findings when they are developed a bit further early next year. So thank you so much.
So thank you very much, Georgia. I should have mentioned at the start that we do have the Q&A panel open, so anyone can enter some questions. I have a couple of questions, if that's okay, whilst our participants are thinking. So you're studying a range of teams in different organisations. I was just wondering, how do those organisations differ in how they assemble the team? And have you noticed any sort of best ways to assemble teams? Like call for volunteers, or do they get assigned, or how does that work?
Yeah, a massive range, I suppose. So some of them, and we definitely see, I suppose, anecdotally or qualitatively influence on the outcomes of these teams. You know, some of them we've spoken to, they said, oh, you know, yes, it's a new team, but I've been working with these guys for 20 years. You know, they've in universities, particularly in the US, where people tend to stay there for most of their career. To a degree that happens in Australia in healthcare as well, but definitely I think in the US that's been the case. And you can see just in the way they speak about their experience, where there's been really that lack of hierarchy, and also importantly comfort with disagreeing with people, because there's that sense of personal relationship beyond professional or beyond those occupational identities. So in that sense, you know, that's great. We can more broadly, you know, there are some challenges with just working with people that you've always worked with and that you know quite well. You know, in the sense that you tend to work with people that are like you. And what we know in this particular type of work is that divergence of ideas is really important. Whether that's because of a different style of thinking or that multidisciplinarity, people coming together from different backgrounds, that divergence is really important. And so sometimes you don't want almost too much comfort because you don't get that divergence in thinking differently. So I think there are some challenges sometimes with that approach of working with people that you've always worked with. There are challenges with not working with people that you've always worked with, in the sense that, particularly in Australia, often these sorts of programs are, they're still not a routine part of the healthcare system, and funding wise, often it's either a collection of grant funding. What I'm trying to say is that often people are attending these meetings in their spare time, and so you really need to be able to create the space for that, but then motivate and engage people to participate, and that's easier, you know, when you have kind of well-established relationships. I suppose the last thing that I'll mention is that I've seen or just noticed already a really interesting difference between the interdisciplinarity that exists in the Australian programs versus the US programs. And that is that typically the Australian programs be quite, to varying degrees, and less so perhaps the WA program, but very genetics focused, understandably. And typically the consultation with other specialists is a bit more peripheral or kind of ad hoc. Whereas many of the US teams are bringing those other specialists along to every meeting to really engage them for every patient. And I'm unsure at this stage which approach is the right approach, if there is one. But there's definitely been that difference, I suppose, in how the teams are assembled and who's brought along. So I'm really interested to dig into if there are any associations between those structural differences in the outcomes of the meetings.
Yeah. Okay. Thank you. There is one question, but I've just got to ask my second, if that's okay, whilst we still give others time to add. So I can imagine, so it's fantastic these groups are working together, and it's also great that they are open to being examined, I guess, and studied. But have any of them commented to you that the fact that they know that you're looking at what they're doing means that already they're changing the way they're interacting, or you know, so I know there's ethical issues. You can't just have a fake mirror and watch them, and or maybe you can, I don't know. But anyway, so has your study actually already resulted in them self-reflecting and changing how they operate?
Yeah, that's a really good point, and massive challenge in psychology in general, and this sort of research. And there was definitely a period of time early in our work with the West Australian program where it was just, you know, we would just kind of attend the meetings and just be flies on the walls to an extent, and not record, not take notes, and just establish that sort of familiarity until I think to an extent we did kind of just become normal participants or a normal part of the meeting. So I think that hopefully helped. What has also been helpful to some extent and has become a sort of then a variable in the study is that in this expanded version of the project, we've gone from what was, even at the best of times, not the most innocuous setup of attending these in-person meetings and setting up little microphones and cameras, and it was all a bit, a little bit clinical, although I think over time there was familiarity with it. But what we do now with all of these other teams is most of the meetings are via Zoom. So it's just like we are today, clicking record and hoping that decreases the degree to which that might influence things. But ultimately we can't test for that, and we just try and implement these different measures to reduce that, and to, of course, part of that is also assuring people of the confidentiality of the information, the security of the information, particularly when it comes to patients as well. So we do our best to try and reduce that, but that is definitely always a factor, and hopefully one that we've, as much as we can, kind of accounted for.
Yeah, that sounds great. Very challenging and well done. So there is a question. Do you recommend any ground rules for behaviours and interactions in the diagnosis meetings? And if so, what rules have been found to be helpful in creating an effective meeting?
Yeah, that's a really good point. And I think it was so great to observe in particular the West Australian program and some of the rules that Gareth and his team had kind of implemented just off their own bat, of trying to figure out what works best, and at least something that they do, a couple of things that they do that I sense works quite well, and obviously empirically is something that we're still ascertaining, but there's a sense that I get is one thing that he does is, just the basic thing of going through the patient's details, the history, presenting the information, and then just going around the room and giving everyone the opportunity to speak, and making sure, establishing that's okay if you don't have anything to say, but just in case, I'm going to go around and give everyone the opportunity to kind of say their piece. Sounds pretty simple, but I think that makes a big difference, again, in these kind of contexts where it can be a little bit hierarchical. And in Gareth's team in particular, they do tend to have people, peak of their career, experts in the field, but also they have students sometimes who come along, and people who are more kind of mid-career. So I think that really helps. Gareth, says many a times throughout the meeting that no idea is too silly, really kind of reinforces that. And something that I've noticed from him and his team as well, that I see happen in some of the others, is what we would call kind of disclosure, or being comfortable saying that you're unsure about something, to set the precedent that it's okay to be vulnerable in that sense. So I definitely think the role of the facilitator is massive in creating that environment. And then also in responding to when people do show that vulnerability. I remember vividly a meeting that we went to where a rheumatologist or a specialist had brought a sheet of paper of things that she'd been Googling at home to try and figure out what was going on with this patient that were very much outside of her specialty. But the way that was received was super positive. And not that, there's still a need to be clear about what ideas may be great idea, but it's probably not that one, and it's probably not, not the answer in this case. It's not a case of, I think sometimes people feel worried or feel a need to be overly positive and accepting all the time of everything, but there's something that a distinction that we make in psychology between relationship conflict and task conflict. Relationship conflict tends to be the bad kind, where it's conflict on the basis of personal characteristics or a personal relationship. But task conflict, when it's a disagreement about the nature of the task, what is right or wrong in terms of the answer, is good and needed often in this sort of case. So I think some of those different strategies that Gareth and his team have implemented seem to be working quite well, which is both about encouraging ideas, making that safe environment, but also encouraging discussion and disagreement, which I think is crucial in these sorts of contexts. So those are things we've observed in that team. And we're still, as I said, unfortunately collecting the data on the rest of the teams, and I'm really interested to explore that further. One last thing actually that I will mention that I found very interesting was in one team, and I think it is just the one, So typically in the Australian programs and the US programs, it's the geneticist, which Gareth is in this case. I swear I'll stop putting him on the spot. I hope he doesn't mind too much, but typically it's the geneticist who runs these meetings. And in general, they tend to be described by other people on the team as very personable, friendly type of people. In one of the US teams, it's a nurse practitioner who runs the meetings. There is still kind of the lead geneticist who's kind of there a little bit more in the background. But this nurse practitioner runs the meetings, facilitates them. And some people have said that really makes them feel like there's perhaps less of a hierarchical environment than there might be if you have someone who's a doctor or really kind of senior in their field leading those meetings. So I'm interested to see if we can tease apart some effects of that or differences between those teams.
Okay, thank you. And that question came from Martin Anderson. And again, there's another question from Martin. I would be interested to know whether artificial intelligence has been used to help assess the wide range of symptoms and suggest possible diagnoses to the team.
Yeah, really great question. And again, I will flag, not a doctor, not a technology person, but my understanding is definitely the West Australian team, and I think to some degree some of the Eastern States programs, not so much that I've heard of in the US ones, but definitely the West Australian one, they use what's called Patient Archive, which was developed by the Garvan Institute. And again, my non-expert understanding of what that does is they will plug in the symptoms using a particular human phenotype ontology, a particular language of standardizing the terms for the symptoms. They will plug that in and it will generate potential diagnoses. I've been in meetings with the WA team where they put the symptoms in and it spits out a number of diagnoses and they laugh because it's just so obviously not that. But I've been in meetings where it's generated suggestions that have been explored further. So I think from what I can tell from my non-expert perspective, it seems to be that there are some interesting developments in this space and that this could provide a massive tool that I think is still working alongside these clinicians in finding diagnoses for patients. But still at the moment, a combination of kind of more manual human-based cognition with that artificial intelligence component.
And Martin says thank you.
You're welcome.
Which is a good prompt for me to also to say thank you. So really interesting and important work that you're conducting, and hopefully it will help that large number of people who do suffer from these rare diseases. And you said, as you pointed out, a large number of rare diseases. So clearly really important stuff. But I guess also some of the principles you're finding could be applicable to other areas of health, but even beyond that, I can imagine just where people are working together to solve problems in a number of different areas. So thanks for your great research. Good luck with it all. And thanks for that really clear presentation, which was just really fascinating. Thanks, Georgia, and well done.
Thank you. Thank you so much for having me. And again, I do acknowledge that it was, even for me, where I've been immersed in it for a couple of years now, it was a lot to kind of put out there. So I'm absolutely more than happy to chat to anyone who has more questions or who wants me to send you some fantastically long academic papers. Happy to chat further and send some more details out if anyone would like them. So thank you so much for having me.
So thank you, and thanks to all the participants that joined us as well. Great. Good evening. Bye-bye.
Bye.